Good morning, everybody. So today we're going to talk about postpartum hemorrhage. I did put a bunch of resources on Moodle that I hope you guys could review before today's class. So let's get started. What is postpartum hemorrhage? So postpartum hemorrhage is when a client has very heavy and irregular vaginal bleeding after birth. This is usually over 500 milliliters for a vaginal delivery and over 1,000 milliliters for a C-section within 24 hours. So it usually happens within 1 day of giving birth, but it can happen up to 12 weeks after having a baby, so it is very important to educate patients on, what to look out for and what to do in case of this type of emergency. So there are the 4 T's of postpartum hemorrhage, which are the main causes: tone, tissue, trauma, and thrombin. And I have a little chart here that talks about how often these things happen and which ones are the most widespread. So tone is the most common. This is uterine atony, which is just very soft, weak uterus, where usually it's so tired it can't really clamp down on those bleeding vessels and help with any bleeding. Tissue usually is referring to retained placenta. So if there are pieces of the placenta that are still in the uterus after delivery, usually the body starts trying to rid those pieces by profuse bleeding. Also, those vessels cannot be clamped down because they're still attached to that placenta. So it's that blood's coming out of those areas as well. Trauma refers to laceration, which is the second most common type. This is basically just lacerations from like tearing, those things from delivery that the doctor does not see right away. And so they're just left to bleed until the doctor can recognize those things and suture those lacerations. And then thrombin, which is very rare. In my personal case, this is only really seen very rarely, and usually the woman knows she has bleeding disorders when she comes in. So things can be put into place to help with these precautions for bleeding. Next, we have the risk factors. So there are a lot of risk factors that put women at higher risk for postpartum hemorrhaging. Placental complications would include abruption and previa, which just basically it's just making that the previa is making it harder for the placenta to come out at delivery because that placenta is kind of covering the cervix a little bit. And then abruption, just whereas that placenta attaches from the uterus, making it a little trapping that blood in those sections that it's separated from. Multiple pregnancies. So this is actually a really big risk factor that I see often in my line of work. So twins, multiple babies in the womb really wear out that uterus and can make it more likely for her to bleed, as well as having more babies. So if she's on her 8th and 9th baby, her uterus, the walls of her uterus are very thin and weak because it's had to stretch out and go back down to normal size so many times in her life that the more pregnancy she has, the higher risk it puts her for postpartum hemorrhage. Things like preeclampsia, infection, obesity put them at a really big risk for postpartum hemorrhage. Prolonged labor and precipitous deliveries are also very common risk factors. Prolonged labor, think of it as using a muscle a lot. If you're lifting a lot of things, by the time you're done, your arms are weak, they're shaking, they're hurting, they just don't feel right. So if a woman's laboring for multiple days, by the time she gets to delivering the baby, her uterus is wore out, it's tired, it doesn't want to do what it has to do to go back down to normal size because it's just tuckered out, it's ready to be done. So the longer uterus stays really big, the more likely her bleeding will increase until it can go back down to normal size. Precipitous deliveries as well. The uterus stays pretty big because everything happened so fast. She delivered within an hour of being at the hospital. Her uterus is very stunned as to what just happened, and it takes a lot longer to go back down to normal size. Uterine atony, we had kind of already talked about. This is just when it's just so weak and soft that it's hard to really bear down and clamp down on those bleeding vessels. So this is a question I want y'all to read and answer. All right, and this is the answer. A 6.5 pound infant after a 1 hour labor. So this is an example of a precipitous delivery that would put the mother at higher risk for postpartum hemorrhage, as we had talked about in the risk factor section. Signs and symptoms. So this is what you're really going to look out for if you think your patient is hemorrhaging. So the first thing, not really the first thing you'll see, but something that's very specific to this is the hypotension and tachycardia. She's losing a lot of fluid volume, so she's going to have a low blood pressure and a high pulse. You may not see this immediately either, but she'll have a low H&H. Hematocrit and hemoglobin will be critically low, and she'll probably need blood, if not at the hemorrhage, the next day. Heavy vaginal bleeding usually means soaking their peripad within 1 hour, along with large blood clots or frequent blood clots. Very big risk factor. So you want to educate the patient on looking out for those things, especially if they're going up and changing their pads in their bathroom after delivery anyway. Small ones here and there are okay, because if she's sitting in the same position in her bed for a long time, she's going to have some of that coagulation take place with that blood that's pooling in her uterus. But large blood clots, frequent blood clots, usually means her bleeding is on the heavier side. And then watch how the patient's feeling. Is she dizzy, lightheaded, nausea, vomiting? Those things are something you'll have to keep an eye out for. Usually, in a case of a postpartum hemorrhage, the patient's able to tell you, I just don't feel good at all. But if they lost a lot of blood in delivery and the next day they are saying that they're dizzy, lightheaded, it could just be from the low hematocrit and hemoglobin from the day before's events. And then watch out for that sweating, pale skin tone. Here's another question for y'all. It's a select all that apply, and we'll talk about all the answers. So the answers are slow, steady trickle of blood, blood clot the size of an orange, and a boggy uterus. So, like I said, small blood clots are normal. You really want a firm uterus. Moderate lochia rubra is completely normal, especially after delivery. She's gonna be bleeding. Moderate to small to moderate are normal charting numbers, I guess you could say. And lochia rubra, would be that bright red blood that we do expect after delivery. You do want her fundus to be felt at the midline, and at the umbilicus is fine, at or below the umbilicus, depending on where she is and how far out from delivery she is. But you definitely want it to be midline. If it's deviated to the sides, it can mean that her bladder's full, which could also increase her bleeding as well. So you don't want a steady trickle of blood, because that's going to mean that there's a lot of continuous bleeding going on that you don't want from the uterus. The blood clot the size of an orange is way too large, and like I said earlier, a boggy uterus is that uterine atony that we don't want at all. So we want to make sure we massage that and firm it up really good for her. Next, we have nursing interventions. So you're going to want to do these things if you see a patient that is hemorrhaging. Now, I do want to note that many hospitals and facilities do have protocols in place for postpartum hemorrhaging that are like order sets that someone can put in, and a bunch of stuff will be ordered for them. But you do have to know what to expect and what to know to do in case of this. So the first thing you're going to want to do is massage that fundus and call for help. You're not going to really call the doctor from immediately. You want to call for help. Get that patient as stable as you can. Get other nurses in there to help start IVs, give fluids, start Foley catheters, those types of things. You want her bladder to be empty because that might be contributing to her bleeding. Assess those vital signs to see how stable she is. You're going to expect to see that hypotension and tachycardia, but you still have to keep track of it to see if it's getting worse or better. Give some IV fluids to help try to start to replace all the fluid she's losing. Hopefully you can get blood up there really fast to start replacing her blood levels. Uterotonic medications we're going to discuss in a minute, but you're going to want to give those as fast as you can. And then order labs like hematocrit and hemoglobin, and make sure she's type and screened for receiving blood, and that those things were all in place before this, so that you don't have to worry about it in that moment, just getting her stable and getting her the help she needs to help her patient outcomes the most. You're also going to want to know what some doctor interventions are, like the Bacri balloon, Jada system. You might have to bring that patient to the OR room for a hysterectomy and a DNC. So we're going to talk about the Bacri and Jada in just a minute, but a hysterectomy is kind of our last option. If everything you're doing is just not doing enough for her, they're going to have to take that uterus out because it's causing so many issues. And then if the doctor is concerned that the patient is retaining some of that placenta, they're going to have to do a DNC to really scrape out that uterus and make sure everything's good moving forward. So a Bacri balloon is basically a really big catheter that the doctor puts into the uterus, and you blow it up with saline, and it holds pressure on those vessels that are bleeding. It's just like holding pressure to a wound. It's not super invasive. It has a high success rate. It works often. And it's a fast and effective way. So you want to make sure you have the kit ready, you have saline, those type of things, because the doctor is going to need you to hand stuff to them really fast in order to get this in there and get it blown up. And then we also have the JADA system, which is fairly new. This is kind of a suction. So this actually works really well because when the doctor puts it in the uterus, it actually sucks the uterus down to it and is able to, one, it can collect all the blood that's in the uterus and you can accurately measure it, and two, it helps bring the uterus down to its normal size, unlike the Bacry balloon, so that it helps really clamp down those blood vessels and hopefully keep it that way. So here's another question for you guys. I want y'all to read and answer it. And the answer is to palpate the fundus and massage. So no matter what, you have to do all these things, right? But the most important one to do immediately is to palpate that fundus and massage it to try to get it firm to help the patient out. And then get some help in there to help do the rest of the interventions that are needed at that time. So now we're going to do a group activity. I want you guys to separate into 4 groups. I'm going to assign each group a uterotonic medication, and you'll have like 5 to 10 minutes to create a poster and kind of present it to the class on the medication. All right. So now y'all are separated. Group 1, you'll have Pitocin. Group 2, Cytotec. Group 3, Methergin. And Group 4, Hemabate. I'll give y'all some time to make your posters and we can talk about it. Alright guys, so now that we've had some time to talk about it, here are the uterotonic medications. So this is kind of just a really good table to keep in mind. When you are discovering what medications to give, make sure you know the contraindications. So Pitocin and Cytotec are the only 2 that really don't have any contraindications. Methergin and Hemabate do. So it's very important to know these things because a lot of these protocols that are in place in hospitals let you use these medications without the doctor's order. So you have to know what your patient looks like, what their problems are, because you have to be able to work around these contraindications that they may have. So here's another question for you guys to answer. And the answer is Methergin. So it says a preeclamptic woman, which means she already has hypertension. So we know a contraindication for Methergin is hypertensive patients. So we would not give this in any way. We would definitely massage. Pitocin's always a really good first line medication, and she can also have Cytotec. Alright, so to conclude the class and make sure you guys learned something today, we're going to do a little role play activity. I want you all to separate into groups of 5, determine who's going to play the patient, primary nurse, charge nurse, patient, family, and doctor. And after, we'll talk about the scenario and everything. The scenario is on the next slide, and then after we'll do a little conclusion about what we learned, okay? So now that everybody's into their groups, this is the scenario. A 32-year-old woman gave birth 1 hour ago to her 5th healthy 6-pound boy. Upon entering the room, the patient complains of feeling a big gush. When the blankets are drawn back, the nurse notices the pad is full of bright red blood and numerous large clots. Pitocin is infusing at 40 milliliters an hour and her fundus is boggy, and these are her vital signs. What should you do? I'll give y'all some time to kind of work through the scenario and talk about what you would do, and then we'll talk about it after. Alright, you guys, y'all did so good in that scenario. So here's like a little conclusion. I just want to make sure we kind of sum it all up. So remember to massage the fundus first, call for help, get other nurses in there, including the charge nurse. Call that doctor to get them headed to there as soon as possible. Ask the family to step out of the room so that more staff can come in and help. If you kind of take the time to explain to them, hey, we want to make sure that she makes it out of this and that she has the best outcome possible. We need as much room as we can. You're going to want to make sure you keep all of those pads so that you can try to measure her quantitative blood loss after all this is over and she's stable, because that's going to help with those interventions moving forward. And then the postpartum hemorrhage is fast and critical, so work as fast as possible. Make sure you have great teamwork and communication with the people that are in the room helping you. All right, y'all. Y'all have a great day, and I will see y'all tomorrow.